Hi everybody, and welcome to our module on chronic kidney disease. Chronic kidney disease is a slow, steady fall in creatinine clearance, and the words slow and steady are important. Patients who have a sudden, rapid fall in creatinine clearance have acute renal failure that can develop over hours or days, and I talk about that in another video. Patients with chronic kidney disease have a fall in creatinine clearance that evolves over months and years. And blood tests in these patients will show a consistently elevated BUN and creatinine. That's the hallmark of chronic kidney disease. Eventually, chronic kidney disease progresses to dialysis for many patients, and we'll talk about dialysis later in this video. And the most common causes of chronic kidney disease are diabetes and hypertension. Patients with diabetes develop diabetic nephropathy. Patients with hypertension develop hypertensive nephrosclerosis, and both of these conditions can lead to chronic kidney disease. Rarely you will see patients with chronic kidney diseases with other causes. For example, glomerulonephritis can cause chronic kidney disease, so can cystic kidney disease. We categorize chronic kidney disease by stages based on the glomerular filtration rate. So a normal GFR is greater than 90, and patients who have stage 1 chronic kidney disease have maintained a normal GFR, but they have a rise in BUN and creatinine, or they have protein in the urine. They have some evidence of chronic kidney disease, even though their GFR hasn't yet begun to fall. Stage 2, 3, and 4 represent progressive lowerings of the GFR. Patients in stage 4 are approaching dialysis. And finally, patients with stage 5 CKD have a GFR that's less than 15, and usually these patients are on dialysis. Patients with chronic kidney disease are at risk for a number of adverse outcomes. The first one, obviously, is progression to dialysis. But beyond this, what you really want to know for your boards, this is very high yield, is that patients with chronic kidney disease are at very high risk for cardiovascular disease and infection. Patients with CKD have a risk of cardiovascular disease similar to patients who already have established CAD. So they have rates of stroke and myocardial infarction that are very high. This happens because CKD leads to accelerated atherosclerosis, and the most common cause of death in adults with chronic kidney disease is not renal failure, it's cardiovascular disease like stroke and MI. In addition, patients with CKD are immunocompromised, and infections are very common. In fact, infections are the most common cause of death in children with CKD, and they're the most common cause of death in patients who have kidney transplants for CKD. Renal replacement therapy, or RRT, is the fancy name for various forms of dialysis, which we'll talk about in just a minute. And in general, renal replacement therapy is indicated when patients have a GFR that is less than 5, or a GFR in the 5 to 15 range, but one of the AEIOU indications for dialysis. So the AEIOU indications are acidemia, electrolytes, meaning hyperkalemia, intoxication, meaning an overdose of a dialyzable substance, and we'll talk about those in the next slide, an overload of fluid, meaning congestive heart failure and pulmonary edema, and finally uremic symptoms, and symptoms of uremia are pericarditis or encephalopathy. And of all the AEIOU indications, the most common that are used to indicate the need for dialysis are hyperkalemia and volume overload. Patients who have chronic kidney disease often develop these things and then have to go on dialysis. Shown on this slide is a list of dialyzable substances, meaning substances that can be removed from the blood by using dialysis. And they're usually remembered by the mnemonic SLIME for the first letter of each of the 5 substances. The S is for salicylates, meaning aspirin. The L is for lithium, the I is for isopropyl alcohol, the M is for magnesium laxatives, and the E is for ethylene glycol. So patients who have overdosed on one of these substances are sometimes referred for dialysis to remove these substances from the body more rapidly. Now let's talk about dialysis methods. There are 3 major methods of dialysis, and we'll go through each of them one at a time. The first method is hemodialysis. This is also the most common way that dialysis is performed. Hemodialysis requires special vascular access, and we'll talk about this in a few slides. Patients usually have something called a fistula placed for access for dialysis. Once that access is available, blood is pumped from the body through a filter and then back to the body. So essentially the filter is doing the job that the kidneys normally would do. This is a picture of a man hooked up to a dialysis machine shown on the screen here. Patients with chronic kidney disease who require dialysis usually go to several sessions of hemodialysis, a few hours at a time. Usually they go 3 times per week to a dialysis center. They're hooked up to a machine like this. They can read a book or watch a movie, and after 3 hours they're done, and then they come back again a few days later. In addition, hemodialysis can also be done emergently in special situations. So for example, in a patient with acute hyperkalemia, emergent hemodialysis could be arranged in order to reduce the plasma potassium level. And the main risk of hemodialysis is hypotension, so a large volume of fluid is removed from the body when patients have hemodialysis, and this can drop the blood pressure. And so for this reason, hemodialysis is usually done for patients who are stable in the outpatient setting. It's not usually done for critically ill inpatients who may have low blood pressure. Those patients usually can't tolerate the volume shifts of hemodialysis. Second dialysis method is called peritoneal dialysis. In this form of dialysis, fluid is cycled through the peritoneal cavity in the abdomen, and the peritoneum is used as a dialysis membrane. If you look at this drawing on the screen here, a fluid is pumped into the abdomen and substances diffuse back and forth across the peritoneal membrane, and then waste drains out into a bag. The patient has to be able to attach a catheter to a pump in order for this to work, and the pump needs to cycle for about 4 to 6 hours per day. Usually this is done at home during sleep. So this is a method of dialysis for select patients who are highly motivated and are willing to hook themselves up to the pump at night so that they can be dialyzed while they sleep. The advantage of this method is that patients can do it at home during sleep and they don't have to go to a dialysis center 3 times a week for hemodialysis. The major risk of this form of dialysis obviously is peritonitis. Since you're inserting catheters into the abdomen, what can happen is the catheters can have bacteria and that can lead to peritonitis. Final method of dialysis is called hemofiltration. This method involves the constant slow filtering of blood. This is usually done at the bedside and usually done in critically ill patients. This is a picture of a patient hooked up to hemofiltration in the ICU shown on the screen here. And because the rate of filtration is slow, this form of dialysis usually doesn't cause hypotension. So this can be done in critically ill patients who may have soft blood pressure. The disadvantage of this is that it runs continuously, so it's only done in the ICU in patients who are bedbound and are being treated for critical illness. This is sometimes referred to as CVVH. I just tell you this so you'll recognize it when you hear it on the wards. This stands for chronic veno-venous hemofiltration. The H is for hemofiltration. Let's talk about vascular access. If you want to perform hemodialysis on a patient, you need to have access to the vascular system. For acute dialysis in someone who has acute renal failure and hyperkalemia, a central line is usually placed. But for patients who are going to be outpatients, going to outpatient hemodialysis 3 times a week for a long period of time, the ideal method of vascular access is called a fistula. This is a surgical connection between an artery and vein placed somewhere in the body, usually in the arm. And the reason this is used is because it's been shown in studies to have the lowest rate of thrombosis and infection. You can't leave a central line in patients for long periods of time. The central line will become infected. Fistulas, on the other hand, can remain for long periods of time, and the rates of infection and blood clots are very low. The way that vascular access through a fistula works is shown in the drawing on the screen here. A surgeon places a connection between an artery and a vein, usually in the arm. What this is going to do is cause high pressure blood from the artery to flood into the vein, and the vein will become massive and engorged. You can see these on patients who have fistulas. Once the vein is massive and engorged, it's easy to use for access. You can connect the dialysis machine to it. That will draw blood into the machine, and then another line will send the blood back. And so now what you've got is blood going out of an engorged vein into a hemodialysis unit and then back to the patient. After the fistula is placed surgically, it has to mature. It usually takes several months for this to happen before the flow really gets vigorous through the fistula. So ideally, vascular access through a fistula is placed several months before a patient goes on dialysis. When patients are approaching dialysis, nephrologists will refer them for a fistula so that a couple of months down the road, if the kidney function gets worse, they are ready to go. So we already talked about how the most important complication of CKD is cardiovascular disease. That's the most common mode of death for patients with CKD. But now let's go through some of the other complications that patients have with CKD. The first one is anemia. So the kidneys produce erythropoietin, so when you have chronic kidney disease, you lose EPO, and that leads to anormocytic anemia. Patients with chronic kidney disease have abnormal platelet function, so they are prone to bleeding. And then we've already talked about how patients with CKD commonly develop infections. This is because neutrophils don't function normally in patients with CKD. Chronic kidney disease leads to dyslipidemia. Usually the elevation is mostly in triglycerides. One of the reasons for this is because protein is lost in the urine, and this stimulates the liver to synthesize more protein, and along with that, the liver will produce more triglycerides. In addition, patients who have CKD have poor clearance of chylomicrons and VLDL particles, and so for all of these reasons, they can develop abnormal lipids, especially hypertriglyceridemia. Sexual dysfunction is very common in patients with CKD. Men develop erectile dysfunction, and women who are of reproductive age develop anovulation. And then finally, chronic kidney disease leads to important abnormalities of calcium and phosphate, so let's talk about that now. This slide shows what happens to calcium and phosphate levels in patients with CKD. So when the kidneys are sick, they do not excrete phosphate normally, so patients with CKD commonly have hyperphosphatemia. In addition, the sick kidneys do not activate vitamin D, so you have decreased levels of the active form of vitamin D. This leads to less calcium being reabsorbed from the gut. In addition, the high phosphate levels bind with calcium in the plasma and pull calcium from the plasma, so this leads to less calcium in the plasma. So these combination of effects on calcium lead to hypocalcemia. So most patients with CKD have both hyperphosphatemia and hypocalcemia. And then finally, hypocalcemia triggers the parathyroid gland to produce PTH. So in patients with CKD, the parathyroid hormone level gets high. Most patients with CKD develop secondary hyperparathyroidism. This means the parathyroid gland is being stimulated to release PTH because of the low calcium caused by renal failure. Left untreated, however, secondary hyperparathyroidism can turn into tertiary hyperparathyroidism. In tertiary hyperparathyroidism, the parathyroid gland has been stimulated so long from chronic hypocalcemia due to renal failure that it becomes autonomous and it just constantly releases PTH, and the levels of PTH can get very high. When this happens, the calcium becomes elevated, and these patients often need a parathyroidectomy to control the calcium level, because basically what's happened is their parathyroid gland has gone rogue and it's releasing parathyroid hormone constantly. The only way to treat this is to take out the glands. Because of the abnormalities of calcium, phosphate, and parathyroid hormone in CKD, patients commonly develop bone disease. So if you don't treat the hyperparathyroidism of chronic kidney disease, patients will develop what's known as renal osteodystrophy. This is a collection of pathologic changes that occur in the bones, and clinically it can cause patients to develop bone pain. This is the predominant symptom, and it also sets them up for fracture. Their bones become weak because of the chronically high levels of PTH. Patients with CKD are also at risk for developing the bone disease osteitis fibrosa cystica. This is a bone condition that develops when patients have long-term, untreated elevated levels of parathyroid hormone. Any cause of chronically elevated PTH can lead to osteitis cystica. It could be parathyroid disease, but it can also be from kidney disease. Patients who have this condition develop cysts in their bones, big spaces without bone tissue, and also what's known as brown tumors. These are collections of osteoclasts and fibrous tissue. If you look at this slide on the screen from a patient with osteitis cystica, you can see these dark spots here. Here's another one right here. These are brown tumors, and these are seen in patients who have long-standing untreated elevations of parathyroid hormone. Let's talk about some of the treatments used for chronic kidney disease. ACE inhibitors are prescribed in patients who have early CKD, and the reason is because ACE inhibitors have been shown in clinical studies to limit the progression of CKD to dialysis. Now you may know that ACE inhibitors can cause a small rise in the BUN and creatinine. For this reason, they're only used in early CKD when patients do not yet have severe renal disease. Those patients are usually able to tolerate a modest dose of an ACE inhibitor. Patients with chronic kidney disease are placed on a renal diet if they have advanced CKD. There are a couple of elements of the renal diet. First of all, it has low protein, which limits the urea production by the liver. The renal diet also has low levels of potassium, phosphate, and magnesium, because patients with advanced CKD have trouble excreting all of these substances. And then finally, when you consume salt, you retain water, and that raises your blood pressure. So the renal diet also has a low salt component if the patient has hypertension. In addition, patients with heart failure should not consume high levels of salt anyway, because the retention of water that goes along with the salt can lead to heart failure symptoms. And finally, patients who are oliguric with advanced CKD make very little urine. So if they eat a high salt diet, their body will hold on to water and excrete less water, and that will worsen the oliguria, potentially progressing the kidney disease to the point where they're not making any urine. So also for patients who are oliguric, a low salt diet is recommended as a component of the renal diet. Patients with chronic kidney disease should take vitamin D and calcium supplements. And the idea here is to prevent the hypocalcemia that we talked about earlier that leads to chronic elevation of parathyroid hormone levels. In addition, I told you earlier that patients with chronic kidney disease have chronically high levels of phosphate, and that can lead to a complication known as calciphylaxis, which we'll talk about in just a minute. So in order to bring down the phosphate level in the plasma, patients with CKD take what's known as phosphate binders. These are substances that bind phosphate in the GI tract to lower the serum phosphate level. I've listed a few of the phosphate binders here. They include calcium carbonate, calcium acetate, which goes by the trade name Foslo, sevelamer, which goes by the trade name Renagel, and lanthanum. And there are others beyond those listed here, but the idea is the same for all these substances to bind phosphate in the GI tract and lower the serum phosphate level. There are a number of drugs that can worsen renal function. These drugs lower the GFR and are associated with increases in BUN and creatinine. And in general, we try to avoid these drugs in patients with chronic kidney disease. One group of drugs that can worsen renal function are the diuretics. These include loop, thiazide, and potassium-sparing diuretics. We sometimes use these in patients with CKD if they have a compelling indication like heart failure, but whenever possible we try to avoid these drugs to prevent the BUN and creatinine from rising further. NSAIDs can also worsen renal function. Remember that the afferent arteriole brings blood into the kidneys, and the patency of the afferent arteriole is maintained by prostaglandins. So when you administer NSAIDs and you limit the production of prostaglandins in the afferent arteriole, that will lead to vasoconstriction of the afferent arteriole and therefore less blood flow to the kidney. So for this reason, patients with CKD are usually advised to avoid NSAIDs. In addition to the drugs I just mentioned, CT radiocontrast dye, which is dye injected into the vascular system for CAT scans, is usually avoided in patients with CKD. That's because it can lead to a special form of acute kidney injury called contrast nephropathy. This is a CT scan of a patient who has a pulmonary embolism. This black stuff here is a blood clot. In order to see that blood clot, you need to inject contrast dye into the venous system. That's what makes the pulmonary artery white like this. But you can't do this in a patient who has CKD because the contrast dye may shut down the kidneys and cause that patient to need dialysis. The reason we give phosphate binders to patients with chronic kidney disease is not just because they have high phosphate levels, it's because those high phosphate levels can lead to what's known as calciphylaxis, also called calcific uremic arteriopathy. This is a complication of hyperphosphatemia seen in chronic kidney disease. In calciphylaxis, phosphate gets taken up by vascular smooth muscle, often in the skin, and then the smooth muscle starts to turn into bone. In other words, it undergoes osteogenesis and the walls become calcified. This raises the systolic blood pressure and it also sets blood vessels up for thrombosis. And for this reason, patients with calciphylaxis develop these painful nodules and skin necrosis in areas where the vascular smooth muscle has been calcified. This is a picture of a skin lesion of a patient with calciphylaxis. And the reason we give phosphate binders is to decrease the serum phosphate level so that this won't happen. You have to use caution if you refer a patient with CKD for an MRI like is shown in this picture. The reason is because patients with chronic kidney disease are at risk for a very rare condition called nephrogenic systemic fibrosis, or NSF. In this condition, patients develop diffuse fibrosis of the skin, so it's a terrible condition. All the skin in the body can develop induration, thickening, and hardening. The skin takes on this darkened color. It's described as a brawny hyperpigmentation. It's also shiny. And this skin condition is believed to be a reaction to gadolinium, which is an MRI contrast agent. If you have a patient with chronic kidney disease and you expose them to gadolinium, those are the patients who develop NSF. So for this reason, MRI with gadolinium contrast is contraindicated in patients with CKD. This is a systemic condition, affects all the skin of the body, and there's no treatment. Some MRIs can be done without gadolinium contrast. Those MRIs are okay, but if gadolinium is going to be used, you can't do that in a patient with CKD. And I'll finish with one slide on kidney transplantation. Kidney transplantation has been shown to reduce mortality compared with dialysis for patients with advanced CKD. In addition to lowering the mortality rate, it's also associated with improved quality of life because patients no longer have to go to dialysis 3 times per week. In general, kidney transplantation is reserved for younger patients who are better able to tolerate the surgery. And in addition, after kidney transplant, patients have to take immunosuppressive therapy, and this is associated with an increased risk for infections. And finally, if you look at this drawing on the right side of the screen, in patients who have CKD and have a kidney transplant, the damaged kidneys are left in place in the retroperitoneum, and the transplanted kidney is attached in the groin to the iliac artery as shown here. And if you see patients who have a transplanted kidney, you can palpate the transplanted kidney in the groin. And the reason it's done this way is because the surgical operation is much simpler to simply add the transplanted kidney in this location. It would be much more complex in order to dissect into the retroperitoneum and remove the damaged kidneys. And that concludes our module on chronic kidney disease.